Thank you for that introduction. Thank you again for this opportunity to come before you, and thank you to the organizers of the conference for having me here again. The topic here is multivessel PCI, and the topic that was assigned was new paradigm after Prami, which is a trial that was done with multivessel PCI and STEMI. I actually changed the topic because we have new data since Prami. So my new title, if this works, yep. So the updated title is New Paradigm After Complete, which is the new clinical trial that was done for multivessel PCI after STEMI. And I will go over the data that we have. Here are my disclosures. So what we do know is that multivessel PCI, multivessel disease, is extremely common. It is seen in about 30 to 40% of patients that present with acute ST elevation myocardial infarction. So this is not an uncommon problem. What we don't know is whether we need to treat the culprit vessel or do complete revascularization, whether it is in that immediate hospitalization or when the patient comes back in a staged setting. And we do have data now for this, but I will go through that systematically. So I'll start with the case example. This is a male patient, 63 years old, that came in with inferior and lateral STEMI with an EF of 50%. And you have these angiograms with an RCA that has distal disease and mid disease. There's some thrombus in the mid RCA. And then you have the circ as well with a very tight lesion in the mid vessel into a large OM branch. And the question is, what do you do and what is the culprit for the patient's MI? Is it the RCA? Is it the circumflex? In this case, it was not as clear. With ST changes in both the inferior and lateral leads, we fixed both. But the question remains as to whether you treat the culprit or you treat multiple vessels in the same setting. So I'm going to go through a lot of data. The first trial that we have is the HELP AMI trial, specifically looking at this, and I'm only going to go through randomized trials. So that limits it to about 5 studies, and we'll go through each one of them. So the HELP AMI study looked at not a lot of patients, just about 70 patients, with 17 patients that were treated for just a culprit lesion and 52 patients that were treated for complete revascularization. And if you look at the various endpoints, including death, repeat MI, revascularization, you see that the p-values are not significant on the right side, so there was no significant difference between the culprit and the complete revascularization. So it was noted that complete revascularization is safe, but there's no added benefit from this particular trial. Then we had the study looking at the same topic again, published by Politi in 2010 in Heart. And if you look at this, they looked at culprit only versus staged revascularization versus complete revascularization, all in the same hospitalization. And so if you compare that first column with the other 2 columns, you'll see that there's a significant difference. Patients did much better when they had complete revascularization compared to culprit only. And you'll see that the p-values are significant here. And if you look at the Kaplan-Meier curves, again, culprit only is the only one that did very poorly for both of these MACE and repeat revascularization curves. And you'll see that the stage revascularization and complete revascularization did pretty well. So doing all of the vessels that have disease seem to do well in this clinical trial. So culprit-only angioplasty was associated with the highest rate of long-term complications compared to complete revascularization. Then we had Dambrink study that was published in Eurointervention, again looking at the same topic. And if you look at MACE events and both per protocol and intention to treat, those are the 2 graphs that you see. You'll see that the conservative strategy, which is treating just the culprit vessel, did the best here. So there was no increase in EF or a reduction in MACE by treating all of the lesions in this presentation. So again, contradictory to the previous study, it didn't show an improvement with complete revascularization. And now we come to the topic of the Prami trial, and this was published in the New England Journal, and now we're getting to much larger studies. This was published in 2013. This had 230 patients in each arm between preventative PCI, which is treating all of the lesions, versus no preventative PCI, which was just treating the culprit lesion. And you'll see that there was significant difference in both the primary endpoints, including repeat revascularization with the statistical significance. And if you look at the chart again, comparing preventive PCI versus no preventive PCI, the preventive PCI did better with hazard ratios that were significantly better. And so again, this trial, larger study, suggesting that we should probably do complete revascularization. So in patients with STEMI and multivessel disease, preventive PCI in non-infarct coronary arteries with major stenosis significantly reduce the risk of cardiovascular events, pointing towards multivessel PCI. And then there was the culprit trial. This was published in JACC in 2015, again on the same topic. And what you see here again is reiteration of what we found in the previous trial in Prami. So on the left is complete revascularization, on the right is culprit vessel only. And you'll see that there's a significant difference in total MACE events here, with the red line being infarct-related artery and the blue line being complete revascularization. So the MACE events were significantly lower when you did complete revascularization in this subset. And then this was a meta-analysis looking at all of the trials that I just went over. So this is all the randomized clinical trials that we had up to this point. Those were the 5 trials that I went over: culprit, Dambring study, HELP AMI, Politi study, and the Prami trial. And if you looked at the overall events across, and this is a very busy slide, but if you just look at the graphs, almost in everything for MACE, for MI, for death, and for revascularization, they all favored complete revascularization. So this is a meta-analysis and a review of all of the trials that have been done to date. So again, pointing towards complete revascularization in acute MI. And then we had the biggest trial of them all, and so this is the complete trial, and this is why I changed the name or the title of the presentation today. This was published in New England Journal. This just came out in 2019, and if you look at this, you had over 4,000 patients, 2,000 in each arm of complete revascularization versus culprit lesion only. And looking at all the outcomes, if you look at the clinical significance here, if you looked at cardiovascular death or myocardial infarction, or the secondary endpoint of ischemia-driven revascularization, you saw significant improvement with complete revascularization. And if you look at the charts, the Kaplan-Meier curves again on these 2 outcomes, significant improvement. This was up to 4 years of follow-up. That maintained the difference between culprit lesion and complete revascularization. So complete revascularization did significantly better in this largest trial to date, looking specifically at this question of culprit vessel versus complete revascularization in MI. So finally, ending with the case, again, this is another STEMI patient, clear inferior MI with an occluded thrombotic RCA that was treated appropriately with a good result, but then also had this distal left main and prox LAD and prox diag or into a ramus lesion that was actually FFR'd, and FFR was positive, and so they were stented with a great result. And so you could also approach this as an FFR or physiology-guided result at the end in these settings. So in conclusion, randomized clinical trials overwhelmingly at this point favor complete revascularization as opposed to just the culprit vessel. We may need further evaluation for determination of clinical significance, whether that is stress test or using FFR. And then the optimal timing, we still don't have an answer for, whether that is immediately at the time of hospitalization or if it is coming in as a staged procedure at a later date. And with that, I will end my talk, and I'm happy to take any questions. Thank you for your attention.